Hi there, it's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
Hey everyone, thanks for coming again. So part two, very excited. So again, just as Sarah mentioned, I just want to talk about the letter A, and it's for antibody and also autoantibody. And as you guys remember, antibodies are a protein that's made by the immune system, specifically the cells called the B cells here in our body, and they produce antibodies that really protect us from a lot of harmful invaders like bacteria, as drawn, and viruses. And once these antibodies latch on to these invaders, they allow the rest of the immune system to do its work and to essentially get rid of these invaders, keeping our body safe. Obviously, these antibodies that are made, they're very specific. All these antibodies are circulating in our body. They're very specific to certain things. So, for example, this antibody is binding to specific parts of the bacteria, which allows it to basically latch on, allowing the rest of the immune system to attack it. Now, autoantibodies are essentially, as the name suggests, it's antibodies that go a bit crazy and that attack your body or yourself. And this really develops due to many reasons, including family history, certain environmental triggers. They say viruses, many things can trigger this event. And essentially, when this happens and the autoantibody level becomes so high or becomes so great, it can lead to an autoimmune disease. And that includes, rheumatoid arthritis, systemic lupus are good examples of this. And this is just a diagrammatical sort of representation where you have abnormal B cells that are producing these autoantibodies that are, again, abnormal, and they can start attacking things such as in rheumatoid arthritis. The antibodies actually, autoantibodies contribute to the mechanism of disease that is seen in rheumatoid arthritis. All right, folic acid. So this was I think a request, but folic acid essentially is a very important vitamin for your body. As you guys might have already heard, folic acid for a number of reasons. The first is folic acid is a must for pregnant females, and that's because it's very important to have adequate levels of folic acid, this vitamin that your body normally has anyway from diet and whatnot. Because if you have low folic acid, it can lead to this condition called spina bifida, where essentially the nervous system, the spinal cord and all that, they don't develop properly. Because folic acid or folate is very, very important in the development of these structures during, the baby growing inside the womb. So that's the importance of folic acid in pregnancy. But normally, you and I, we normally eat, vegetables, green vegetables, which contain really a lot of folate naturally. And so that's how we get our folate level normally. But I think a group of you might know folic acid because you guys, maybe some of you take methotrexate. Now, methotrexate is a medication which I sort of touched on before, and I think Dr. Selke has talked about this in a separate video. But it's important because it really ties into folic acid. This diagram looks really, really confusing, but basically what it's trying to show you is that folate is very important in the production of your genetic material, which is DNA. And so folate, again, is very important in the production of your DNA. And so, if your folate levels are low, it can really cause some abnormalities in your body, such as your blood counts might look a bit abnormal, and also your wound healing, for example, might be a bit off. And that's because, again, your body's missing this key vitamin. Methotrexate, drawn here, is actually a medication that we use commonly which inhibits a particular enzyme. An enzyme is a protein that is important in catalyzing reactions in our body, but it inhibits this important enzyme, this important protein called dihydrofolate reductase, which is important for folate to make DNA. I hope you guys are following me. And so, because of that, we recommend patients to have folate so that it can replenish any folate that's not really being used to make DNA. We're basically making sure we're overloading the body a bit with folate so that it can still have folate to function properly. Now, methotrexate is a medication. This is really important. Methotrexate is a medication we normally take, or people normally take once a week. But there are cases where patients accidentally take it every day. And when that happens, that's not very good, obviously, you can imagine, because when you take it methotrexate every day, you're really not allowing any folate, nothing to really be produced. The DNA is not producing properly, and you can get a lot of toxic problems, including mouth ulcers, amongst many other things. And so there is an active form of folic acid, which is an intravenous form. They give it by drip, and that sort of bypasses. This is folinic acid on the corner here. And that's what we give for really toxic patients who's had toxic effects from methotrexate if they've taken too much accidentally. That's a kind of an important point because it bypasses this actual enzyme, as you can see here, to make DNA down the bottom. I hope that made sense. Is there any questions about folic acid?
Not yet.
Awesome. All right, good.
But feel
Awesome.
free to pop them in if
Yes,
you're still
please.
mulling that over.
A few weeks ago when I did my first talk, I was going to talk about NSAIDs, but I think someone in the chat talked about neutrophils, and you know what? I chose neutrophils. So for those who don't know, neutrophils is a type of immune cell. It's very, very important, actually. So you know when you get your blood report, this is an example of a blood report. And in the blood report, this one specifically, it's your blood count. So you have your hemoglobin, you have your platelets, you have your white cell count. White cells are your immune cells. And white cell count here, this is normal. It says 6.89. But under the white cell count, there's different types of white cells. And you can see neutrophils are marked here. They make up a large proportion of your white cells in your blood. And that's because they are very important. Neutrophils you can think of as the first immune cell or white cell that really responds to anything, including infection. And they're sort of, I like to think of them as kamikaze cells, those cells that sort of just go in and burst and try to stop the infection or control the infection. So just to draw it out for you guys, I mean, you have your blood vessels and they contain a lot of things, including your red blood cells, which carry oxygen. And these are your white cells. These are your neutrophils. They normally circulate around your body and they're ready to defend you against any harmful invaders. The neutrophils are really unique because if you look at them under a microscope, they contain these granules that really contain a lot of chemicals to help basically kill invaders or kill bad stuff. And they also contain many nuclei, which are the power, basically the main hub of what makes a cell. So essentially, you can imagine if a bacteria, for example, you get a cut or you get an infection from a leg wound or whatnot, they can enter your tissues, they can enter your body. The neutrophils will go in straight away because they're really the first line. And what they do is that they will engulf this bacteria and they'll kill it using the chemicals. But that's not all they do. They can release a lot of chemicals. It's like cytokines, which are basically proteins that help drive an inflammatory response. But they also are like kamikaze cells. They burst and really just spreading all these chemicals to try to kill all the bacteria around them. Neutrophils are really what make up pus. So you know when you know an abscess or you know when a pus occurs under your skin, that's your neutrophils basically breaking down and releasing chemicals and killing any nasty stuff. I hope that makes sense. So After N is O. O is for osteoporosis. And this is a very important topic or disease that we encounter in rheumatology in our clinical rooms. So osteoporosis essentially is when your bone becomes brittle, and this and weak, and this tends to occur with age, which is very, very common, and predominantly affects females, and that's because of hormonal changes. So osteo really pertains to bone. Osteoporosis is porous because the bone is porous. You can see here, this is when you look into a bone, this is what a normal bone should look like. It's quite dense, very strong. But in osteoporosis, the bone is porous. And because it's porous, it's easily breakable. This diagram on the left here showing you basically a 55-year-old person going down in size over time. And the reason for that is they're experiencing fractures in their spine without even knowing it. And that's due to osteoporosis. They have over time weakening of the strength of the bone weakens, become porous, and the vertebrae, the spine sort of starts squeezing against each other, resulting in shortening over time. There are many, many, many risk factors for osteoporosis. I could sit here for a few minutes and rattle off, but I think the most important thing is age, um, being female, and the reason is especially after menopause, because estrogen is very important in protecting your bones, and it actually sort of prevents osteoporosis, you can say. So when your estrogen levels go down after menopause, your bone health also sort of goes down a little bit too. And aside from that, I think another very important risk factor is uh, prednisone, which is a very common medication that people use in rheumatology and that we prescribe. And I'm going to talk about that next. But I guess what can you do? What can you do about osteoporosis? Well, in order to prevent it, in order to prevent it, weight-based exercise is actually very important. And I think BJC also has some exercise sort of programs to help osteoporosis patients because bone strength with weight-bearing activity is the best thing by far. Obviously, smoking is another big risk factor and alcohol, so we always tell patients to stop that. There are other risk factors, but I'm not going to go into it. But that's essentially osteoporosis, and we want to prevent it by weight bearing, by increasing muscle mass, and whatnot. There are treatments for people who have osteoporosis, which is again diagnosed by a special scan, and the treatments are really driven. They can be driven by us, but predominantly by the GPs as well. And they include things like Prolia, which is every 6 months, or bisphosphonates, which is tablets that people take weekly or monthly. And these help essentially strengthen the bone by stopping cells that sort of break down the bone slowly over time. Okay, so that was O. If there's no questions, I'm going to move on because this one's a good one. So P is for prednisone. So to be honest with you, prednisone is there's a stereotype amongst doctors, amongst doctors that rheumatologists just give prednisone. That's all they do. But we love prednisone, but we also hate prednisone. It's a love-hate relationship. So prednisone, you are aware, it's a medication we use because it really helps settle inflammation very, very quickly. So this diagram I sort of stole from the autoantibody diagram, and it's just meant to represent, the immune system becoming abnormal and attacking the body, and you get inflammation of the joints, for example, and also the neutrophils, which are also very important in inflammation. They can also be part of this whole immune system attacking your body, for example. Prednisone is an oral tablet, and this is just a diagram of a dose, but it really stops or suppresses the immune system. It's an immunosuppressant. Prednisone works in many ways in the immune system. It targets many proteins and is itself a hormone. It's essentially a chemically synthesized natural hormone that we produce called cortisol. So it's basically a cortisol in a bottle. It's a uh, it's an it's a hormone that really targets the genetic material in our body to really stop producing anything that promotes inflammation, essentially. So it's an anti-inflammatory and it's an immunosuppressant, and it works in many ways. Whilst prednisone is very good at controlling inflammation and the immune system, it's got a lot of side effects. That's very important to know. And that's why we often do not like patients to be on prednisone for a long time, especially high doses. However, saying that, some conditions you need to be on prednisone. So, for example, polymyalgia rheumatica. And there are other things that patients need to be on prednisone for a long time. But I'm just discussing in general, if we don't have to, we'd rather stay away from prednisone for too long. So let's look at these side effects. This is important in the short term and long term. In the short term, the most common thing is you get maybe some insomnia, especially if you take it at night, because it's a stimulant. It really makes you feel energized in the short term. Um, and I guess in the short term, it can also give you pain relief, especially if it settles the inflammation, and that's what it's meant to do. But in the long term, and this diagram I'm trying to represent all these side effects that people can get. And I'm not trying to scare people, but it's just important to understand why rheumatologists really like to see their patients, especially if they're on prednisone, to make sure that we can adjust the doses. So weight gain is by far the most important, because weight gain, and it's not just your standard weight gain. The weight gain goes to specific areas under your face, on your shoulders, and around your gut. Very specific. And that obviously comes with complications, if you gain too much weight. It also causes stretch marks, bruising, easy bruising, thin skinning, and red flushed cheeks, as well as weakening your bones over time. I'm talking about long-term use, which is osteoporosis. Um, but if used properly in short bursts, it is very good, and it is one of the key things we all rheumatologists use in their clinic, because it's very effective when we need it. I couldn't think of Q except for quiescent disease. This was a hard one.
That is a hard letter.
Yeah.
Wondering what
Um, so, so I mean, people sometimes use this term. It really just means a state of someone with a rheumatological disease or disorder that's not very active. So there's no active disease. So for example, if if there's a patient with rheumatoid arthritis with swollen joints and it's very painful, that's obviously active disease. Quiescent disease means someone without any disease activity, any symptoms. They feel pretty much normal. That's what we call quiescent disease. But it is very different to remission, which is the next.
good
R
segue.
is,
You're
yeah.
getting tricky now. You're linking
Yeah, this is
letters. Ah, this is
yeah, this is
yeah.
getting, yeah, but look, R is for remission, and this is different to quiescent disease, because remission of disease is actually a defined uh it, there's a specific definition, and it's actually based on a criteria. So it's like a checklist. So anyone that, and this is, I'm talking about rheumatology, by the way. If someone comes into our clinic, I mean, if we want to say that they're in remission, we 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 don't really tend to pull a checklist and tick the boxes, right? But that's essentially what it is, technically. And that's why the word remission, it's only really used in research for rheumatology and medication. When we use the word remission, the definition is very broad, and it doesn't mean that the patient is off medication. I think the term remission is very different to what doctors think and what patients think. And I might be wrong here, but I think the word remission makes it sound like, off medication, nothing. They're like completely symptom-free, no medication, nothing. But for doctors, for rheumatologists, the word remission really means that their disease is very controlled whilst on medication. So this is just some examples of these criteria I was talking about for remission. And these are mainly used in research for medications that come up in the rheumatology world. And this is just an example of rheumatoid arthritis. There's like 4 here. And it's so much, there's so much debate around it because no one really knows what the best sort of criteria is. But that's just for you guys to sort of understand that every disease, systemic lupus, psoriatic arthritis, all of these conditions, they have their own criteria for remission that really is mainly for research. And this is just an example of one of the criteria. You got to meet all these things, but I'm not going to bore you. But it's just like it's important to understand what remission is to us. So I'm sorry to do this, but S is actually for a lot of stuff. I realized that S was like A in the first part. A had like 3, but S, there's a few. And I think these are very important terms, at least in rheumatology. So the first S is for synovitis. What is synovitis? Well, I want you guys to imagine this is your hand, and your hand are made out of joints, and these joints are your synovial joints. I talked about this in the first part, but the synovial joint is the most important joint, one of the most important joints in your body because they're the joints that help you move. Your fingers, your elbows, your shoulders, everything is synovial joints. And it's called synovial joints because they're made up of the synovial membrane. They contain the synovial membrane, which is essentially a membrane here in brown that produces fluid that sort of lubricates the joint. And this is very important because it allows for movement and allows for a lot of other functions and nutrients and whatnot. So this synovial joint is made up of a synovial membrane. So synovitis, itis means inflammation. Syno means the synovium. So it's inflammation of the synovium. And this is what we see in inflammatory arthritis. Nearly all of them, but more specifically, rheumatoid arthritis. Rheumatoid arthritis is characterized by synovitis. That is the definition. So this is an example of what happens when you have inflammation of the synovial membrane. You have thickening, you get red, and it starts producing a lot of fluid, and you get a lot of immune cells to the actual joint. That's synovitis. And so you can imagine if with rheumatoid, for example, they get boggy, swollen joints, that's the synovium being inflamed. That's the synovial membrane being inflamed and producing a lot of fluid. So what happens over time, though? If you keep the synovial being inflamed, what happens? Well, over time, it can cause damage. And that's very important to understand. And that's why we always want to stop this. We want to stop this process as soon as possible. Because once damage occurs, you can't really get it back. We want to try to prevent any form of damage. And that's with prednisone, that's with treatment, which is very important. So I think this was a really a high request. S is for, and I talked about this last time. So the other S is for seropositive or seronegative. So to put it simply, seropositive and seronegative means basically the presence of autoantibodies or the absence of autoantibodies in respect to a particular disease. So what I mean by that, let's look at an example. This is a patient in the background, let's just say that has rheumatoid arthritis. So again, it has to be a specific disease. So rheumatoid arthritis, it's a classic condition. We tend to divide them into seropositive rheumatoid arthritis or seronegative rheumatoid arthritis. Seropositive rheumatoid arthritis means that they have autoantibodies in their blood. So when you check the blood, you get these results. You get either a positive rheumatoid factor or a positive anti-CCP, which is anti-citrullinated protein antibody. These are autoantibodies. That means seropositive. However, some patients present very much like rheumatoid arthritis or very similar, but they have no antibodies for rheumatoid factor or this anti-CCP. Some rheumatologists would label them as seronegative rheumatoid arthritis because they're rheumatoid, but they have no antibodies. Why is this important? Well, this is important because they've done so many studies with these with people with either seropositive or seronegative, and they know how essentially the trajectory of these patients. Some are a bit more aggressive than others, and that really changes how rheumatologists manage these patients. Another example for seronegative and seropositive is something called spondyloarthritis. Now, you might know this condition because it's a group of conditions that affect the joint that connects your pelvis to your sacrum. This is known as the sacroiliac joints. So you might have heard of conditions such as ankylosing spondylitis. But even other conditions like psoriatic arthritis, they can also affect this particular joint. These conditions that affect the sacroiliac joint, they come under the umbrella term of spondyloarthritis. Now, I don't want to confuse you too much, but this is another type of inflammatory arthritis. And we also call this particular condition seronegative because there's no antibodies to diagnose this condition or associated with this condition. Now, with lupus, that's a completely different entity, but lupus, there's some belief that there is seronegative lupus, but I think a lot of the rheumatologists don't agree with that. There has to be some form of antibodies with systemic lupus. All right, so I just wanted to quickly segue to this sacroiliitis because I don't know if some of our patients here or someone might know, but sacroiliitis again is inflammation of this joint here, and it's a common condition in ankylosing spondylitis as well as a number of conditions, including psoriatic arthritis. But this is just to show you what happens, as the disease, if the disease progresses, because it's quite interesting because here you can see the joint being separated, the pelvis and the sacrum. You can see a line in between here, but as it goes from grade 1, 2, 3, 4, the sacroiliac joint starts to fuse as a response to inflammation. And this is basically this fusion of the sacroiliac joints causes stiffness in the lower back, and this is pathognomonic for ankylosing spondylitis.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events and access our team of facilitators live. All of the details that you need to join BJC Connect are now flashing up on your screen. But otherwise, like our staff, subscribe if you'd like to see more information from BJC Health. Look forward to seeing you in an event soon.